Nothing I do goes really fast, and I know I'm going to gain the ire of Binay, but I'll try to go as fast as I can in 15 minutes. And I'm going to have 5 questions for you. And this is really based on just things from my own clinical interest. Between ASH, it should be 2018, and ASCO 2019. So the first one here is if you have a 50-year-old man with stage 2 nodular lymphocyte. Oh. Okay. All right. I hope this doesn't count on my. All right. I don't know if you guys have seen the commercial about the slow skis, the turtles. I feel like I'm Mr. Slowski, and Binay wants young Slowski on the podium right now. So 5 clinical scenarios, 5 different patients. The first one, a 55-year-old man with stage 2 nodular lymphocyte, so CD20 predominant Hodgkin's lymphoma, no B symptoms, and an ECOG score of 0. Optimal therapy consists of, and as you can see up here, radiation therapy, chemo, combined radiation and chemo, rituximab plus or minus whatever else you want to add, or active surveillance. All right, so I think we'll stop right there, and I'll just present this really. Oh, we're getting kind of some spreads. So 57% favored rituximab plus or minus something. And this is a paper that came out in Blood earlier this year from Memorial Sloan Kettering, and it was basically a 40-year experience, and you need that kind of experience to gain insight into this kind of Hodgkin's variant. But as you can see here, that a lot of the patients in this cohort or in this long series of patients were monitored in a watch and wait group, and a large number of them never needed any treatment at all. And so when we look at this group of patients, they have a uniquely good prognosis, and I think the answer probably is E, which is active surveillance. So more just to be aware, rituximab is certainly a good choice. But there doesn't seem to be an advantage of treating these patients early as opposed to watching them kind of like a follicular low-grade B-cell lymphoma patient without bulk disease. The next slide has to do with something I've been completely unaware of, and yet 2 weeks ago it got its FDA approval. And here I wrote on June 10th, 2019, the FDA granted accelerated approval for polatuzumab, a CD79 directed antibody drug conjugate indicated in combination with benda and Rituxan. In a difficult patient group, what were the results? And so everyone, the largest group favors C, a 53 response rate, maybe changing a little bit, and I'm going to stop it here and we'll look to see what the actual results were. It was actually D, and I thought this was pretty incredible. So this is a difficult to treat group, and with benda, Rituxan, and an antibody drug conjugate, the response rate was 63%, and there was a 40% CR rate. And in the group that got just bendamustine and Rituxan, the CR rate was 14%. So this is a big change, and this may give us maybe, I'm not sure where this is going to be positioned in truth, but it may be another option for patients who aren't quite ready for CAR T-cell in terms of transitioning to a CAR T approach. And I have a patient who fits the mold who is not ready for CAR T-cell. And I called Genentech, and one day they said, we're not ready. And the next day, they said, we're up and ready, and you can get this drug really fast. So more just FYI. The next, this next slide is a 44-year-old man, and he has a history of easy bruising and mild shortness of breath on exertion. He has a good performance status, but he has a white count of 64,000. He's anemic, and his platelets are 22,000. A bone marrow biopsy reveals AML, and flow cytometry shows it's CD33 and CD34 positive. And cytogenetics show a good prognosis in version 16. What would you favor as your choice of therapy for this patient? Standard 7+3 plus Gemtuzumab, just 7+3 alone. CPX-351, which is a liposomal preparation of Dano and Cytarabine, or FLAG-IDA. I think you guys did pretty well. I would say that it's probably 7+3 plus now Gemtuzumab. And this was something that was presented at ASH, and it was basically in 2017, the FDA repurposed Gemtuzumab and approved it for use. Back in 2010, they had taken it off the market because of the higher incidence of veno-occlusive disease and higher risk of death for patients who received it. The dosing was different, and there was a reanalysis of 5 trials looking at Gemtuzumab at a different dose. And as you can see from this one right here, in the left, which was kind of an addition of all of these trials put together, the good prognosis group, the ones with the favorable cytogenetics, had a clear benefit to using Gemtuzumab. And the doses are very different than what had been used before, which was 9 milligrams per meter squared on a day 114 schedule. This is a smaller dose, 3 milligrams per meter squared on days 1, 4, and 7, and then during maintenance, a lesser dose too. And that's a big difference. And so for the lucky group, and oftentimes we think of throwing more at the worst group, but in the lucky group that has good prognosis, who may not be considered for transplant, adding Gemtuzumab might be a really good idea. So the next case is also a patient with newly diagnosed AML, but on the other end of the spectrum. He's 80 years old. He presents with bruising, and he has a poor ECOG score of 2. He has a white count of 13,000. He's anemic, and he's thrombocytopenic. He has 29% blasts on peripheral blood. And he doesn't, and if you're waiting for the mutational studies to help you decide what to do, his came back, and FLT3 and IDH were both negative. He has 48% blasts. And what would you recommend for this patient in terms of chemotherapy? So Azacitidine and Decitabine, a hypomethylating agent, and Venetoclax, or Arac, plus Arac, standard 7+3. No one's choosing CPX-351, which is good. And I put hospice referral because until last year, I think hospice referral would have been a really appropriate option for such a patient. I think our standard treatments for this patient are so poor, and the hoops that a poor performance patient was going to get into was a suggestion that there was no improvement in overall survival. But Venetoclax was definitely the superstar of 2018. We heard from Ryan. We heard actually about multiple myeloma, at least in a subset of BCL2 positive patients. And in ASCO, we heard about it being used for breast cancer too. So it's a pretty interesting patient, but for AML and for MDS, it really stole the, stole the presentations. And this was really one of the registrational studies that looked at treating patients such as this, elderly, unfit for perhaps standard chemotherapy, and giving them a ramp-up dose of Venetoclax in conjunction with either of the hypomethylating agents, Azacitidine or Decitabine, or Cytarabine. And really, the results, which you'll hear about in a talk just after this, were nothing short of remarkable. And so I have a patient exactly like this in the hospital right now, and that's exactly what we're treating them with. And Azacitidine, maybe a little less toxic than Decitabine. Cytarabine sub-Q is really cheap, and that might play into how we approach these patients and which one to connect with Venetoclax. But it looks like the 400 milligram dose is probably the best dose, and that's usually ramped up over 3 or 4 days. So I think we got here hypomethylating agent plus or Arac plus Venetoclax. So this one is a riff off the last presentation and MGUS, and it's the last one here. We'll see how well you retain that talk after 5 minutes. A 72-year-old asymptomatic woman with a good performance status has a 3.2 gram per deciliter M spike, 40% plasma cells on bone marrow, and has a 17p deletion, which we know is a poor risk feature. Kappa lambda light chain ratio is not that high, it's 8, and diffuse marrow infiltrative changes, but no lytic lesions on MRI. And the choices would be, I would offer chemotherapy. This is a 72-year-old, so maybe thinking about CyBorD or RVD. I'd offer chemotherapy and Zometa. I monitor these patients carefully and treat when they progress to active myeloma. And then I apply the Mayo Clinic 2018 risk factor assessment to inform my choice. If at high risk, I advise treatment. So, Wilson, this will be a test to your, to your skills at speaking. Wow, I'm impressed. Everyone said, or a large number said the Mayo Clinic 2018 group for that. I'm not so sure, and I kind of saw this trial and wasn't sure if it was really practice changing, at least not yet for me. I don't want to go through the rationale. Of course, there was the Spanish trial that suggested that using Revindex alone improved overall survival, and that was a very eye-opening thing, but the criteria that was used for high risk isn't standardized, and they didn't use x-rays in the same way that we did to assess for marrow disease. And again, we know what the study looked like. We just heard it. I won't repeat that again. But these are the criteria for high risk and low risk for FISH. It's 17p. For Mayo Clinic, there's the 2008 and 2014 criteria. And I think this slide was really the one that Wilson was kind of pointing to, which was to say that all the groups benefited, but the group that were of intermediate or high risk seemed to benefit the most. Not mentioned was, though, that 50% of the people who were given Revlimid in the second phase of the study ended up coming off the study because of toxicity by 3 years. And in the first half, which was the lead-in, 80% of patients were taken off study due to side effects, either cytopenias, fatigue, or other things. So how well we can incorporate Rev into this group, I think, is really uncertain. So I wrote here, personally, for me, I would just continue to monitor these patients. There may be a group that are at such high risk that 60% already qualifies as myeloma, but I'd say I'll bite the bullet. Some of it might be how anxious the people are to begin treatment rather than defer treatment. But for those of you who said, I apply Mayo Clinic 2018 risk factor assessment to inform my choice, I have one last slide. And it's Donald Trump. All right. Well, thank you very much. I think this concludes our session.
Well, thank you so much, David. Now, I would take 2 questions for the panel from audience.
Can I ask a question? So, Dr. Advani, I was wondering, you presented the lymphoma data, and it was really a whirlwind of information, and I still struggle with the double or the triple hit lymphomas and what to do with them. And I'm wondering what you personally do for those patients.
So I think the most important thing is to go back to the definition. Double and triple hit is by FISH, not by immunohistochemistry. They're completely different entities. So if you have a MYC positive and BCL, we start out with MYC. If the MYC is positive by FISH, then you go ahead and do the BCL2 and BCL6. And if it's positive and it's a true double or triple hit, their outcomes with R-CHOP are not robust. So we tend to use dose-adjusted EPOC in that group of patients and CNS prophylaxis. On the other hand, if it's dual expressor, where it's just on immunohistochemistry, there is no data to support any change of therapy, and then R-CHOP remains the standard of care for that group. Not if they've achieved a complete remission, we don't consolidate with transplant or high-dose methotrexate. If you're using dose-adjusted EPOC, it's intrathecal methotrexate. But if you're using R-CHOP, then you have to do high-dose methotrexate. But R-CHOP doesn't really work if it's a true double hit. And the outcomes of a double hit or for a triple hit is the same. So it's not that you do anything more for a triple hit. And the partner, whether it's BCL2 or BCL6, also doesn't matter.
I have another question. For example,
For a year.
For the Hodgkin's lymphoma.
For 1 year.
For 1 year. It is standard dosing and standard.
Another question. In Hodgkin lymphoma, from a transplant perspective, I have not seen any transplant option in second, third line relapse. We know now that allotransplant actually, especially in patients who are not up to 5 lines of therapy, could be feasible with results even with the haplo donors, which is very possible for the majority of patients. How do you see that? So I was asking if that's something you consider.
No, we absolutely do. I think the standard of care is for Hodgkin's at first relapse is to actually try to get them into remission and take them to autologous transplant. Okay, so allo has been pushed further down the road with the availability of brentuximab and the checkpoint inhibitors. And if you fail those, then definitely allo comes into the picture. The problem we have is, the time it takes to find a match, and it's not available in everybody. But with the haplo data, yes, it's definitely an option out there. The response rate with the checkpoint inhibitors, even on the pivotal trials, is much higher than what you get with allo. So the hope is that on the pivotal trial, people who were on it for 2 years and then had to stop, some of them, their responses have been sustained. And there's also emerging data with retreatment with the checkpoint inhibitors that there's response. So what is happening at the ground level is they get checkpoint inhibitors. As long as they're responding, they stay in it. You try to find a match and see where you are with that. And if you actually have a very robust match and everything, you need to break. You have to give them a 3-month break from a checkpoint inhibitor before you take them to allotransplant because of the GVHD risk. And if you don't have a match, you just continue them. And they can go on it for 2 years, and then you stop, and then you get the washout, and then take them to allo. I mean, I don't think BV or the checkpoint inhibitors are curative. I mean, if you have somebody who has just a partial response and is puttering along, you really need to try to get them to an allo.
I'll ask you a question. And I think, again, this is kind of like in this cutting phase of clinical activity. A 62-year-old man with CLL11 deletion who needs treatment, rapidly rising white counts, some lymphadenopathy. And I've struggled with this. One of the questions is, would it be fair to give bendamustine and Rituxan, knowing I might get 3 or 4 years, and then have a little bit more knowledge on how to segue to a drug like Venetoclax or ibrutinib, or maybe the newer drug, zanubrutinib. So I'm wondering, from a practical point, and this idea of using a drug that costs $100,000+ a year, presumably indefinitely, we may find out later how.
So the other stratification would be the mutated immunoglobulin variable region as well. And so in multiple subset analyses of these chemoimmunotherapy versus targeted agent studies, chemoimmunotherapy does worse for unmutated patients. So that could be another stratification as well. And then the patient just needs to know the risk, so the goals of treatment and the risk-benefit in terms of rituximab, bendamustine. So as long as they have an idea of what to expect with chemoimmunotherapy, it's not unreasonable in that patient, in that population. But I think the immunoglobulin status is important.
Well, since we don't have any more questions, we'll meet at 10:15 for a very, very important session. We have tons of new molecules getting approved and tons of new regimens coming out for those diseases. Now we have exhibit rooms on that side as well as downstairs. Please meet with exhibitors, and I'll see you back at 10:15. Thank you so much.